So Monty Mython, very brief introductions. We're going to be talking about enhanced recovery. We've got three great speakers. We've got Desiree Chappell, TJ Gann, Tim Miller, all key components or partners in the leadership of the American Society of Enhanced Recovery. So Desiree Chappell is going to start. She's a CRNA from Louisville, Kentucky. I've been working on that. Is that okay, that one? I've been working on that for a year now. And she's going to tell us about the state of the art for enhanced recovery. As I said, a board member of the American Society of Enhanced Recovery. Welcome.
So I got a lavalier, so I walk around. I can't stand in one place. I feel very stifled by a podium. So I am Desiree Chappell, and I am a CRNA. And I've been in practice for about the last 10 and a half years at Norton Audubon Hospital in Louisville, Kentucky. Now, I've been a project team leader there over the last several years, or actually a little bit longer than that. But when Enhanced Recovery came to us about 5 years ago, I took the lead on that. And once I started seeing the benefits of it, I got involved in not only our anesthesia team, but in the hospital initiative, the system initiative, and now, as Monty said earlier, I am involved on a national level with the American Society for Enhanced Recovery and also with EBPOM in the meeting this weekend. So I'm not coming to you from an academic setting like many of the people that you're going to hear this weekend. I work in a small community or medium-sized community facility. I'm not a researcher or a scientist. I haven't done any randomized controlled trials. I'm not going to quote my own studies or share with you a litany of studies and detailed protocols. I'm just like many of you, sitting on the stool, delivering anesthesia 40 hours a week, utilizing enhanced recovery in my everyday practice. Now, I've listened to the world authorities that you'll hear here this weekend, and I've read the literature, and I'm convinced that enhanced recovery is best practice. But what has changed my mind, changed my practice, and inspired me to become involved on a national level, and really what fuels my passion and excitement and enthusiasm for sharing my experiences has been the first-hand view of the immediate difference that enhanced recovery has for our patients. And it's rounding on that colorectal patient or that joint patient on post-op day 1, and they're eating and drinking, and they're walking around the nurse's station excited about their progress and their steps. And they're smiling and they're laughing. And I know that because we changed our perspective in our group, in our hospital, and we changed our practice to include enhanced recovery, their outcomes are far better than if we hadn't. So today I want to share with you some experiences I've had and as I've met others across the country that they are having and that you here are as well, right? We're all kind of in this journey together. We're going to talk about the amazing successes that we have, but there are lots of challenges that we face too, and we'll talk about those. And I also want to be very optimistic about the future of enhanced recovery and perioperative care. So I do have a couple disclosures, not so relevant. It's the big green button I always forget. All right, so when you think of Kentucky, it's Derby season. You're going to think of these beautiful rolling hills with all of our horses, and of course our booming bourbon industry there. But what you've probably heard a lot about Kentucky in the news recently is the drug epidemic in our state. We are in the top 3 for drug overdoses in the U.S. right now. But what I tell you is probably killing more people than drugs, guns, and cars combined is our obesity problem and our continued issues with smoking. It's definitely an issue. So that has led to the state of healthcare in the Commonwealth of Kentucky. I show this slide all the time and I ask, is this exclusive to what we are taking care of at our little hospital in Louisville, Kentucky? Absolutely not. Everywhere across this country and across the globe are taking care of sicker, older patients with lists and lists of comorbidities. And we're going to talk about how to optimize some of those this weekend. But when we took a step back and started looking at enhanced recovery for our patients, it wasn't just about being good stewards of our healthcare system and costs for the hospital. It was about improving care for our patients, improving outcomes, and really improving the health of our community as a whole. So about 4.5 years ago, Dr. Shanahan, who's pictured here on the right, brought enhanced recovery to our facility, and he aptly named it ERAS in the Bluegrass, which is catchy and great when you're doing that internal marketing and trying to create a little engagement. This is our core ERAS team up here in the corner. Dr. Patrick Shanahan, one of the medical directors. Dr. John Rowan, who's not pictured. He's an anesthesiologist that helped us get this going. Myself, Carrie Cheshire, our nurse practitioner from our PAT, or pre-admission testing clinic, she by default became our enhanced recovery navigator. And we all know that it takes this multidisciplinary team to make this work, right? You have to have a coordinator or a navigator as well, and she was that person. And then Dr. John Walker, who is one of our general surgeons who's been practicing for the last 35 years or so. And he said he will tell you you can teach an old dog new tricks. He was completely convinced. He was our first surgeon on board, and he still is very proud of what he is doing with enhanced recovery in his patients. Norton Audubon Hospital, just to give you a quick background, we're about a 450 bed facility, part of a larger Norton healthcare system in Louisville. And we do a little bit of everything besides big neuro, obstetrics, and pediatrics. Glad we're not doing those, actually. So just middle of the road community facility. So when we first started our program, we started out like many of you probably have done, and many across the country, with colorectal. That's where all the literature was. And we saw a reduction in our length of stay by half. We went from 10 days to 5 days. That was huge for us. Now, we've seen some numbers kind of float back up a little bit, and I think it's probably because some of the challenges that I'm going to talk about in just a moment. We're working on it, though. We started with urologic surgery, cystectomy with ileal conduit, and nephrectomy shortly after, about 6 months in. We were able to reduce our length of stay by about 1 to 2 days. We recently, about the last year and a half, started doing total joints. When we first started our joint program, we weren't sure that we actually were going to see any length of stay improvement. We did end up seeing about a half to a day for those patients. But what one of the main benefits was improved patient satisfaction and improved time to rehabilitation post-surgery for those patients. So it was really important to look at the fact that it's not always going to be length of stay or cost savings that you're going to see when you implement enhanced recovery. You may see these other benefits as well, and those can be equally as important. And then most recently, we started cardiovascular surgery, which Dr. Shanahan, again, aptly named ERAS for bypass. Although we're still kind of collecting data on that, we already have seen trends on improving extubation times for those patients. So we're slowly rolling it out through all the different service lines in our practice. Now, it's one thing to see data and see numbers, right? And that's great, and we need to talk about those things. But I always think that pictures show a better view of what's really going on the ground. So who's taken care of this patient before? We all have, right? He's post-op day 1, big, probably abdominal procedure, a little small for our patients in Kentucky, but he's tethered to the bed with a PCA, he has an NG tube, he looks quite miserable, not going anywhere anytime soon. Doesn't mean that he didn't have a successful recovery or that he had any negative outcomes. It's just 4.5 years ago, this is what our patients look like. Well, not anymore, because this is what our patients look like now. And actually, this patient is near and dear to our hearts at Audubon. This is Dr. John Rowan, that anesthesiologist that I mentioned before that was part of our core enhanced recovery team. So not only was he a provider of enhanced recovery, he became a recipient of enhanced recovery as well. And this is very typical for many of our enhanced recovery patients to look like this. He's been up walking around, he's been eating, drinking, he looks great. So this is the face of our surgical patient now at Audubon. So the successes are great, and we love to talk about how wonderful our programs are. We all know that there are many challenges to getting an enhanced recovery program up and going and to keep it sustained, which is one of the bigger problems, I feel. So Dr. Gautam Mukala, who's actually here with us now, and Professor Henrique Collette did a piece for the ASA newsletter in 2014, and they talked about why is change so difficult? What are those hurdles and barriers to get a program? What they were talking about was the implementation, but I think these are totally appropriate when you talk about long-term sustainability of programs and compliance. First is lack of awareness, and I'll take it a step further. People may know what enhanced recovery is, or they may have heard about it. They don't understand it, and that's one of the major problems. There's a lack of interest in reviewing the literature. And I'll, again, step further. It's not necessarily that people don't want to read it. It's just we are all strapped for time right now, right? We're working in the OR. It's really hard to get the time to look at the literature. Liability. This is one thing I kind of scoffed at first whenever I saw it. And I'm like, is this really a thing? And I had a couple surgeons actually tell me, if I feed the patient within 4 hours of the surgery and they have an anastomotic leak and an infection, am I going to be liable for that because I deviated from what I've done for the last 20 years? Right? So this is a legitimate concern. Cumbersome implementation. We all know this, right? There is a very steep learning curve when you start this process. It's tough for everyone involved. But if you set a standard early, if you set the expectation on the back end of it, people are going to realize your workload actually decreases. But you have to tell them that when the process starts. And then it's not my job. I can't stand to hear that. It's painful for everybody to listen to. But it is a reality that people feel this way about a lot of things. It's because they don't understand it or they don't know. Or they're experiencing metathesiophobia. You ever tell anybody? I love the little phobias. Fear of change is ultimately what it is. And that's all these problems become barriers because we all are afraid of change. We've been doing things the same way for a very long time, right? So if you feel that these types of struggles and barriers are impacting your ability to implement care, because we know that they can, or the ability to sustain or have compliance in your programs, a couple things that I think could help you get the wheels turning again. One is to create structure. So many of these programs start from grassroots movement, which is awesome because it creates so much engagement and excitement for a program. But what happens is that it can only be sustainable for so long if you don't have a process in place and you don't have top-down support from your administration. So if you can work together with your admin and with that team to create a process and pathway, you can overcome some of those barriers. Continued education. It's not enough to do a big education blitz as soon as you go live and expect that to be able to sustain a program over time. You're going to have turnover. You're going to have that dogma creep. Some of those old ways kind of creep back into practice. And so you have to have a continued education effort for your team and for everyone that touches that patient. Collaboration and feedback. You have to work together as the team and collaborate on a weekly, monthly, quarterly basis. But what's more important than just sitting down and having meetings over meetings over meetings is to actually get some real feedback from the people on the ground doing the program. They are going to help change your message sometimes, but they're also going to help change that process and make it more effective. And then audit and share. And I know a lot of programs, even though you have EMRs, are still collecting data with pencil and paper. And it's very unfortunate, but that's what you have to do. If you're in that situation, don't try and collect every data point. Just go for, are the patients drinking, eating, moving? Are they getting their carb load drink? Do they get GDT and multimodal pain? Keep it simple, sweet when you're doing it by hand. So it's important to collect data, but what's more important than collecting that data is sharing it. And it's not just sharing it with your core little team and talk about how great you're doing. It's sharing it with your entire institution. The providers, administration, and the patients. They all need to know that what you're doing is making a difference. So that's the ugly part of this whole situation, right? And we live in it every day, so let's just move past it and talk about some optimistic things. Which Cleveland Clinic thinks that enhanced recovery is one of the top 10 medical innovations of this last year, and I would say that Monty and probably Professor Collette would beg to differ since they've been doing it for 10 to 20 years. But it is still an innovative process here in the U.S. And I would even go so far as to say, a lot of people talk about being at the tipping point for enhanced recovery and everybody's going to be doing it in the next couple years. I don't know if I completely agree with that. As I travel around academic facilities, yes. Urban areas, everyone's heard of it. But community facilities out in rural America, it's not there yet, right? It's just not. So we still have an opportunity to be innovative in care with enhanced recovery. So what does ERAS 2.0 actually look like? Well, it's everything you kind of been doing or starting out doing, but it's tweaking a couple things. First, it's changing perspective, right? It's not just about talking about length of stay and cost reduction. We need to change it a little bit. We need to talk about, are we seeing changes in opioid prescriptions? Are we managing blood pressure effectively and optimizing that for our patients? Are we talking about brain health, right? We need to change the perspective of the way we look at this. We need to make sure we're updating our protocols. There's some antiquated protocols out there. There's some new, a lot of this evidence is rooted and it's been around for a long time, but there are some newer stuff and you need to keep those protocols updated. Make sure that you have that administrative support. And this is, Geisinger is doing a pretty bold move whenever they're incentivizing providers for following the standard of care, but also they're mandating and they're penalizing care providers if they are not doing the program and not following that standard of care. So I think that if you want everybody on board, you have to mandate it from the top down and say, this is what our institution is going to do. Changing the narrative, and this is another thing for administration and what I mentioned when we talked about changing perspective. When you're talking to key stakeholders, you may have to change your narrative from what you were saying 2 years ago when you're talking about, it's cost, it's length of stay. Well, not so much anymore if we're still operating on that fee-for-service model. What they're talking about now is readmissions because they're getting dinged for it. So maybe that's what your in is whenever you talk to administration. And then team collaboration. It's not enough just to give an order to a nurse and say, I have this core group of nurses, they're going to do what I say, and everybody else, the order's there, so they're going to follow it. It's not. You have to bring more of the team in on the next phase when you talk about enhanced recovery. You have to educate them. They have to be on board as well. So opening up the arms of your team and bringing more people within the facility on it will help you move forward with your program and be sustainable. So the future really is exciting when it comes to enhanced recovery. We just need to be ready for it. First, I think we need to be innovative. And then I'm not just talking about some of the really cool innovative tech things that you can see out in the exhibition hall and that we've heard about with apps and things like that. Those are cool. But I think being innovative actually is going back to those frontline providers that are some of your problem solvers and have some of the best ways to improve practice and improve process. Are you ready for enhanced recovery to be a standard of care for patients? Well, you need a pathway for each service line and you need to standardize care. And I think you need to be ready to shed the rank and the titles, right? Take off the lab coat, take off the name tag. You're all coming together on that team as equals with an equal voice in how to move forward with your program and have real conversations about leadership. And then are you ready to recognize the shift? Now, there are many of us that have started enhanced recovery, have been doing it for a while, and as soon as you do, you soon realize it's not just about recovery. I mean, that's a catchy name and it's great, but what we really are doing is improving and optimizing perioperative care, right, through the continuum. And we must figure out how to lead this and how to connect all those phases of care. That's how we're going to go into the future of this. So we're in these chairs today knowing that there is a better way to care for our patients, whether you call it enhanced recovery after surgery or whether you call it perioperative care. We've all seen it firsthand. It's a win-win for the patient, for the provider, for the hospital system. So I want to implore you today to change your perspective, or maybe just improve your practice, and commit to change your little corner of the world. Implement the knowledge that you gain over the weekend, right? Reach out to us in these national organizations, the American Society for Enhanced Recovery and us at EBPOM USA, and help get guidance and support from us. Even though you feel like this is an uphill battle, because it really is, and even though you may feel isolated and lonely when you're trying to get this started, because you probably are, I want you to know this, you are not. And as you've heard here this morning, we are all in this together, we're all doing the right thing, and we are providing the best care for our patients. So I want to thank you for listening. I would love to hear from each of you and hear about what you're experiencing in your own practice. I think there are a lot of similarities and we can kind of commiserate over the weekend, but maybe come up with some actionable items that you can take home that will make it a little bit easier for you and maybe make the battle not feel so uphill. And also I want to make sure we haven't said it this morning, tweet about us on Twitter, hashtag EBPOM USA 2018. And share on the LinkedIn page and be sure to listen to Top Med Talk as well. So thank you so much.